Now we're gonna discuss Oncology Helicopter Overview, Module 2. In Module 1, Oncology Basics, we've discussed the introduction, cancer definition, cancer hallmarks, and abnormal proliferative growth behavior, genes involved in cancer, and two-hit hypothesis, carcinogens, cancer grading and staging, and cancer management. In the Module 2, we're gonna discuss chemotherapy classification and the principles, cancer management, principles of chemotherapy, cell cycle review, and the chemotherapy treatment types. Cancer management. There are two possible goals for the treatment of the cancer: cure and/or palliation. When the tumor is localized, the physician will choose the cure pathway. And if the cancer is a metastatic cancer, the palliation way is the best fitting solution. And for the locally advanced or stage 3 cancer, it is in between cure and palliation, and it depends on the healthcare team decision and treatment plan. Now we should know more about 3 pivotal topics. First one is the curative treatment, which is considered to engender a small degree of risk of significant side effects or the possibility of cure, indicated when a curative technique, usually surgery, is available and the patient factors are favorable, such as lack of comorbid illnesses. The disease progression is localized if a patient doesn't have metastases with a lower stage tumor. Second topic is about palliative care. It is considered to alleviate symptoms when the risks of significant side effects outweigh the benefit of possible cure, and when there is metastatic disease and the patient factors are unfavorable, for example, presence of comorbid illnesses. Salvage chemotherapy. It is a treatment given after a cancer has not responded to other treatments, standard therapy, and the treatment given for cancer that has come back recurred. And the goal of salvage therapy is to treat the disease and improve quality of life. Now we're gonna try to demonstrate this slide. The effects of various treatments on cancer cell burden in a hypothetical patient. Here, as you can see, the vertical line is all about the tumor cell burden or log scale. And here is the time scale. And as you can see here, the start of the cancer, 1 milligram mass without any symptoms or asymptomatic. And here, if the cancer is about 1 gram, the symptoms are starting to be appeared. As you can see here, 1 gram mass cancer, significance of a 1 gram tumor mass, a total of 10 power 9 cells is the smallest tumor burden that is physically detectable. And these 1 billion cells represent a tumor weighing. Represent a tumor weighing about 1 gram or about the size of a small grape. Clinical symptoms usually first appear at this stage. And from here, from this stage, if the disease progresses to reach 1 gram mass of tumor, or the patient will die. And in this stage, there are 2 pivotal ways. First way is curative way and the palliative chemotherapy. For the curative chemotherapy, as you can see here, curative chemotherapy for the solid tumors such as testicular carcinoma, the tumor burden is initially reduced by surgery and or radiation. As you can see, the tumor reduced below the 1 milligram mass and followed by the treatment of occult micrometastases or secret micrometastases as continued after clinical signs of cancer have disappeared. And when it comes to the disseminated cancers such as leukemia, the curative chemotherapy option is done by applying a chemotherapy protocols. The combination drug chemotherapy reduces the chance of drug resistance, and each drug is chosen to have different cellular site of action or different cell cycle specificity. Each drug is chosen to have different organ toxicity. Here is a treatment with anti-cancer drug and its cycles. The other option is the palliative chemotherapy, as initial remissions are transient with symptoms recurring between treatments, and survival is extended, but the patient eventually dies of the disease. As you can see here, cancer cells become increasingly less responsive to treatment and finally death. Here we should notice that below the 1 gram mass or 10 powered by 9 cells, the patient is asymptomatic, and the patient symptomatic will start from the 1 gram mass and above. Oncology Clinical Practice Guidelines. Guidelines summarize the current medical knowledge, weigh the benefits and the harms of diagnostic procedures and treatments, give specific recommendations based on this information, provide information about the scientific evidence supporting those recommendations, document evidence-based and consensus-driven management to ensure that all patients receive preventive, diagnostic, treatment, and supportive services that are most likely to lead to optimal outcomes. The most famous clinical practice guidelines in oncology are, first, ASCO or American Society of Clinical Oncology, and European Society of Medical Oncology, and National Comprehensive Cancer Network. Now we should know more about the ECOG, which is the Eastern Cooperative Oncology Group. ECOG-ACRIN formed from the merger of the Eastern Cooperative Oncology Group, or ECOG, and the American College of Radiology Imaging Network. ECOG score helps physician and the healthcare team to determine curative or palliative pathway is the best fitting solution for the patient. ASCO guidelines recommend against the use of chemotherapy in solid tumor patients who have not benefited from prior treatment and who have an Eastern Cooperative Oncology Group ECOG performance status score of 3 or more. In 2012, an American Society of Clinical Oncology expert panel identified chemotherapy use among patients for whom there was no evidence of clinical value as the most widespread, wasteful, and unnecessary practice in oncology. ECOG grading score, curative or palliative decision. For the grade 0 ECOG, the patient is fully active and able to carry on all pre-disease performance without restriction. In the grade 1, restricted in physically strenuous activity but ambulatory and able to carry out work of a light or sedentary nature, such as light housework and office work. For the grade 2, the patient is ambulatory and capable of all self-care but unable to carry out any work activities up and about more than 50% of the waking hours. For the grade 3, capable of only limited self-care, confined to bed or chair more than 50% of waking hours. For the grade 4, completely disabled, cannot carry on any self-care and totally confined to bed chair. Finally, grade 5 ECOG, dead. Principles of chemotherapy. Chemotherapy can be indicated in different clinical settings. First, chemotherapy type. Primary chemotherapy, induction of remission for disseminated disease, high-dose aggressive schedule for a short period of time. Neoadjuvant, treat and shrink the cancer before surgery and or radiation. Adjuvant, given after surgery and or radiation, treatment to kill remaining cancer cells. Maintenance chemotherapy, given in lower doses in order to prolong the remission. Palliative chemotherapy, alleviate particular cancer symptoms to improve the patient's quality of life without expecting to reduce the cancer. Oncology clinical endpoints. To understand the clinical trials, we should know the following definitions. First endpoint is OS, or overall survival, which is the time from randomization to death, and it is the gold standard for primary clinical endpoint. PFS, or progression-free survival, which is time from randomization to disease progression or death, whichever comes first, and used to assess therapies targeting advanced or metastatic malignancies. ORR, objective response rate, which is proportion of patients with partial or complete response to therapy, used to assess new adjuvant therapies. CR, complete response, or NED, no evidence of disease, which is the lack of detectable evidence of tumor, and included as a major goal of multiple myeloma treatment. DFS, or disease-free survival, and RFS, which is relapse-free survival, which is the time from randomization to disease recurrence and used to assess adjunctive therapies. EFS, or event-free survival, which is the time from randomization to disease progression, discontinuation of the treatment for any reason, or death, and used to evaluate highly toxic treatments. DCR, disease control rate, or CPR, clinical benefit rate, percentage of patients with complete response, partial response, or at least month of stable disease as a result of their therapy. This graph demonstrates the idea with the easiest, shortest possible way. Here, as you can see, endpoints with relationship to hypothetical tumor size on a time scale. As you can see here on the start with large tumor size, here's the randomization and initiation of primary therapy. And in this stage, initiation of next line therapy. And in this stage, after disappearance of the cancer, recurrence, reappear of the cancer. And in this stage, discontinuation for any reason of the treatment. And here, evidence of disease progression with large tumor size, and finally, death. And as you can see, overall survival starts from randomization and initiation of primary therapy until death. And the progression-free survival, it starts from the randomization and initiation of primary therapy until evidence of disease progression or death. And event-free survival starts from randomization and initiation of the primary therapy until discontinuation of the treatment or evidence of disease progression or even death. And disease-free survival from the time of randomization and initiation of primary therapy until the recurrence. Time to treatment failure starts from the randomization and the initiation of the primary therapy until the discontinuation of the treatment for any reason or evidence of disease progression or even death. Time to next treatment starts from randomization and the initiation of the primary therapy until the initiation of next line therapy. That's it. To understand chemotherapy classification and the mechanism of action, we should make a little bit deep diving to know more about mitosis and meiosis. As you can see here, this is the mitosis. The parent cell DNA replicates and give two daughter cells. And when it comes to meiosis, parent cell DNA replicates two daughter cells, and after that, the end result is 4 daughter cells. We should notice that most of the time, when people refer to cell division, they mean mitosis, the process of making new body cells. Mitosis is a fundamental process for life. During mitosis, a cell duplicates all of its contents, including its chromosomes, and splits to form 2 identical daughter cells. Because this process is so critical, the steps of mitosis are carefully controlled by certain genes. When mitosis is not regulated correctly, health problems such as cancer can result. When it comes to meiosis, meiosis is the type of cell division that creates egg and sperm cells. Ensures that humans have the same number of chromosomes in each generation. It is a 2-step process that reduces the chromosome number by half, from 46 to 23, to form sperm and egg cells. When the sperm and egg cells unite at conception, each contributes 23 chromosomes, so the resulting embryo will have the usual 46 chromosomes. Review of cell cycle. This slide is quite important, and we should exert our utmost effort to understand every single point in this slide. The process of events that a cell goes through in order to divide. An understanding of the cell cycle is helpful to understand the chemotherapy. As you can see here, cell cycle starting from G0 resting phase, cells that are not active, And here, as you can see, cell cycle non-specific drugs are working in this stage. Alkylating agents, anti-tumor antibiotics, platinum agents. And when it comes to G1, in G1, the cell is preparing for cell division by upregulating synthesis of proteins, enzymes, macromolecules, and organelles. S synthesis phase. In this phase, the cell replicates each chromosome. As you can see here, the S phase specific drugs such as anti-metabolites and topoisomerase inhibitors. G2 or second growth phase involves growth prior to mitosis. In the G2, bleomycin is G2 phase specific drug. For the M mitosis phase, as you can see here, finally M phase is where the cell divides through the process of mitosis, and vinca alkaloids and taxanes are M phase specific drugs. The cell cycle, as you can see here, starts on the G0, resting state, cell is not dividing. After that, G1, synthesis of enzymes needed for DNA synthesis. After that, S phase, DNA is replicated, and in the G2, synthesis of cellular components required for mitosis. And finally, M, mitotic phase, cell divides. Then back to G0. Here, cell cycle specific drugs examined: anti-metabolites, bleomycin, vinca alkaloids, and etoposide. They are effective for the high growth fraction malignancies such as hematologic cancers. And for the cell cycle non-specific drugs such as alkylating agents, antibiotics, cisplatin, and nitrosourea, effective for both low growth fraction malignancies such as solid tumors as well as high growth fraction malignancies. The common chemotherapy adverse effects. According to Iranian Journal of Public Health, most common chemotherapy adverse effects are as follows: vomiting 79%, fatigue 74%, alopecia or hair loss 60%. According to current National Comprehensive Cancer Network guidelines, the chance of myelosuppression in patients, specifically neutropenia, is more than 20%. Additionally, with the use of growth factor support, the risk of myelosuppression in patients on chemotherapy is between 10 to 20%. Organ-specific chemotherapy serious adverse effects. We try to summarize the most famous organ-specific chemotherapy serious adverse events. As you can see here is the patient body. The first letter of the drug with a color code represents the place where the side effects are appeared. For example, cytarabine causes chemical conjunctivitis. And second, oxaliplatin, vincristine, taxane causes peripheral neuropathy. As you can see, cardiotoxicity caused by doxorubicin and daunorubicin. And when it comes to cyclophosphamide and ifosfamide, causes hemorrhagic cystitis. Irinotecan causes diarrhea. Bleomycin and busulfan causes pulmonary toxicity. And finally, cisplatin, which causes ototoxicity and nephrotoxicity and nausea and vomiting. Comparison of emetic potential of anti-cancer drugs. We have three main categories: mild, moderate, or strong emetic potential. When it comes to the strong emetic potential, its members are carmustine, cisplatin, dacarbazine, and streptozotocin. And for the moderate emetic potential, or asparaginase, azacitidine, carboplatin, cyclophosphamide, doxorubicin, mitomycin. And when it comes to the mild emetic potential group, its members are bleomycin, etoposide, fluorouracil, methotrexate, vincristine. Dexamethasone ondansetron combination is one of the most effective anti-emetic combination for the treatment of chemotherapy-induced nausea and vomiting. Drugs used in the chemotherapy-induced nausea and vomiting: phenothiazines such as prochlorperazine, 5-HT3 serotonin receptors blockers such as granasetron, ondansetron, palonocitron, and substituted benzamides such as metoclopramide, butyrophenone such as droperidol, haloperidol, benzodiazepine such as alprazolam, lorazepam, corticosteroids such as dexamethasone and methylprednisolone, Substance B, neurokinin 1 receptor blocker, such as aprepitant. And when it comes to the antiemetic activity, the most powerful groups are serotonin antagonist, substituted benzamide, and phenothiazine. Comparison of myelosuppressive potential of chemotherapeutic drugs. First category has the strong myelosuppressive potential, and its members are vinblastine, nitrosourea, cyclophosphamide, cytarabine, doxorubicin. And the second category with intermediate myelosuppressive potential, its members are carboplatin, procarbazine, etoposide, methotrexate, 5-fluorouracil. When it comes to the myelosuppressive potential category, its members are bleomycin, vincristine, methotrexate with leucovorin. Chemotherapy classification: antimetabolites or S-phase specific, monoclonal antibodies, microtubule inhibitors, M-phase specific, topoisomerase inhibitors or S-phase specific, cell cycle non-specific or CCNS, such as alkylating agent, anti-tumor antibiotics, and platinum agents, or hormonal therapies. Chemotherapy classifications and categories members: antimetabolites, azacitidine, capecitabine, cladribine, cytarabine, fludarabine, 5-fluorouracil, gemcitabine, 6-mercaptopurine, methotrexate, pemetrexed, pralatrexate. Antibiotics: bleomycin, daunorubicin, doxorubicin, iberubicin, idarubicin, medozantrone. Alkylating agent: busulfan, carmustine, chlorambucil, cyclophosphamide, dacarbazine, ifosfamide, lomastine, melphalan, and temozolomide. Microtubule inhibitors: docetaxel, baclitaxel, vinblastine, vincristine, vinorelbine. Steroid hormones and their antagonists: anastrozole, bicalutamide, estrogens, exemestane, flutamide, fulvestrant, goserelin, letrozole, luprolide, megestrol acetate, nalutamide, prednisone, raloxifene, tamoxifen, triptorelin, bevacizumab, cetuximab, rituximab, trastuzumab, tyrosine kinase inhibitors, dasatinib, erlotinib or erlotinib, imatinib or imatinib, nilotinib, sorafenib, sunitinib. Others such as abiraterone, asparaginase, carboplatin, cisplatin, enzalutamide, etoposide, interferons, irinotecan, oxaliplatin, procarbazine, topotecan. Now we're gonna demonstrate chemotherapy mechanism of action blueprint, and to have a full understand of this mechanism of action in this slide, we should go back to this slide after finishing studying of module 3. As you can see here, this is the purine and pyrimidine synthesis milestone, and here is ribonucleotides, and here is deoxyribonucleotide, and here DNA, finally RNA and proteins. When it comes to the 6-mercaptopurine and thioguanine, it inhibits the de novo synthesis of purine ring, inhibit nucleotide interconversions. For the 6-mercaptopurine, thioguanine inhibit the de novo synthesis of purine ring and inhibit nucleotide interconversions. And here, methotrexate, inhibition of dihydrofolate reductase, leads to an inhibition of purine ring and deoxythymidine monophosphate biosynthesis. And for the 5-fluorouracil, inhibits deoxythymidine monophosphate synthesis. And after that, deoxyribonucleotides. And when it comes to cytarabine, which terminates the DNA chain elongation and incorporation into DNA and RNA results in altered functioning of nucleotide acids. For the bleomycin, doxorubicin, and daunorubicin, cessation of DNA by an oxidative process. And for the actinomycin, daunorubicin, and doxorubicin, intercalate with DNA, disturbing DNA function. And finally, for the alkylating agents, nitrosurease and cisplatin, alter structure and function of DNA by cross-linking and or fragmenting of DNA strands. Now we're gonna make a little bit deep diving in the mechanism of actions for the chemotherapy different categories. First, we should discuss some basic informations about the DNA and its components before the start of talking about the mechanism of action of chemotherapy, such as anti-metabolites. First, we should know more about nucleotides. A nucleotide consists of 5-sided sugar molecule, either ribose in RNA or deoxyribose in DNA, attached to phosphate group and a nitrogen-containing base. As you can see here is a 5-sided sugar molecule and attached to the nitrogenous base. And here is the phosphate group. The bases used in DNA are adenine, cytosine, guanine, and thymine. This is the structure of the deoxyribonucleic acid DNA. Here adenine, thymine, cytosine, guanine. In RNA, the base uracil takes the place of thymine. It's the basic structural unit and the building block of DNA. These building blocks are hooked together to form a chain of DNA, as you can see here in this graph. The purine base A and G, or adenine and guanine. The purine base A and G, here is the structure of the adenine and guanine in the DNA structure. As you can see here, adenine, which is paired with hydrogen bond to thymine, and guanine, which is paired by hydrogen bond to cytosine to form this DNA structure. Here is the pyrimidine base C and T, cytosine, as you can see here, and thymine. And here is thymine, which is paired by hydrogen bond to adenine, and cytosine, which is paired here with guanine. This slide is about the mnemonic regarding purine and pyrimidine. Purine, pure as gold, adenine, and or guanine. And when it comes to pyrimidine, we should remember this statement: cut the pi, C for cytosine, U for uridine, and T for thymine. DNA structure, as you can see here, deoxyribonucleic acid. Here is the major groove and the minor groove. And here is the sugar phosphate backbone and the base pair between adenine, thymine, adenine, cytosine, guanine, cytosine. And here's the structure of the nucleotide. For example, for the adenine with its nitrogenous base and the sugar, and here is the phosphate group. Purines always pairs with pyrimidines. As you can see here is purine or pure as gold. Its member is adenine, and guanine is paired with cut the pi, which is cytosine and thiamine. Purines always pairs with pyrimidines. It is a crucial statement. Purines always pairs with pyrimidines. Here is the base pairs, thymine, adenine, cytosine, guanine, to form the deoxyribonucleic acid. Now we're going to start the anti-metabolite agents, mechanism of actions. Anti-metabolites, S phase. Antimetabolites are chemotherapy drugs that prevent cancer cells from making more cancer cells, replicating. They trick cancer cells into using the drug instead of molecules it needs to make the genetic material to replicate or DNA. We should know that thymidine monophosphate, or TMP, also known as thymidyllic acid conjugate base thymidylate, deoxythymidine monophosphate, or DTMP, or deoxythymidyllic acid conjugate base deoxythymidylate. DTMP, deoxythymidine monophosphate, consists of a phosphate group and pentose sugar, and the pentose sugar deoxyribose, and the nucleobase thymine, which is a pivotal part of the DTMP. Mechanism of action of methotrexate and the effect of leucovorin. As you can see here, the diet or intestinal flora produce folate, and the folate enters the cell or the target cell. Inside the cell, the folate converted to the FH2 or the dihydrofolate, which is converted to. And as you can see here, the dihydrofolate reductase enzyme catalyzes the conversion of folate to dihydrofolate, and after that to tetrahydrofolate. After that, the tetrahydrofolate is converted to N5N10 methylene tetrahydrofolate, which is thymidylate or deoxythymidine monophosphate biosynthesis, plays an essential and exclusive function in DNA synthesis and proper cell division. Thymidylate synthase catalyzes a crucial step in DNA synthesis by methylating deoxyuridine monophosphate to deoxythymidine monophosphate and using the N5N10 methylene tetrahydrofolate, and the deoxythymidine monophosphate is subsequently phosphorylated to produce thymidine triphosphate, DTTP, which is a vital precursor for DNA replication and repair. When it comes to the mechanism of action of methotrexate enters the cell through active transport process, and methotrexate inhibits dihydrofolate reductase, and as a result of that impair the synthesis of deoxythymidine monophosphate and inhibits DNA replication and repair. The N5N10 methylene tetrahydrofolate is crucial to form adenine, guanine, thymidine, methionine, and serine. Leucovorin rescue. Leucovorin or folinic acid acts as an antidote, functions to limit the myelosuppression for the GIT toxicity, nephrotoxicity, and the neurotoxicity result as secondary to high dosage of methotrexate and other folic acid antagonists. It should be administered 24 hours after methotrexate dose. Administer N5-formyl tetrahydrofolate or leucovorin or folinic acid, which is converted to N5N10 methylene tetrahydrofolate, and therefore bypass the inhibited reductase mechanism by the methotrexate. Tissue toxicity may be permanent if the leucovorin therapy gets delayed beyond 40 hours. Mechanism of action of 5-fluorouracil. 5-fluorouracil, as you can see, enters the target cell and is converted inside the cell to the 5-deoxyuridine monophosphate, which competes with deoxyuridine monophosphate for the enzyme thymidylate synthetase. And as a result of that, the deoxythymidine monophosphate formation is inhibited. The DTMP is needed for the DNA synthesis and the cell growth. Metabolic pathway of cabazitaben to 5-fluorouracil. As you can see here, the cabazitaben as a prodrug is converted to the 5-fluorouracil. 3 enzymes are involved in this conversion: carboxyl esterase, cytidine deaminase, thymidine phosphorylase. Mechanism of action of 6-mercaptopurine. 6-mercaptopurine is purine antagonist, which inhibits DNA and RNA synthesis and acts as false metabolite, which is incorporated into DNA and RNA and eventually inhibiting their synthesis. As you can see here, 6-mercaptopurine is converted to 6-thioinosanic acid or TIMP, which inhibits the formation of the IMP or xanthosine monophosphate, which is converted to 2 important components, AMP and XMP. When it comes to the AMP or adenosine monophosphate, which is interconverted to ADP or adenosine diphosphate or ATP or adenosine triphosphate, and AMP is also a component in the synthesis of RNA, and AMP is present in all known forms of life. The IMP dehydrogenase or inosine 5 monophosphate dehydrogenase plays a key role in the biosynthesis pathway of purine nucleotides by catalyzing the conversion of IMP to xanthosine monophosphate or XMP. which in turn serves as a substrate for the production of guanosine monophosphate or GMP by GMP synthase. Mechanism of action of gemcitabine. First, we should know about the DNA polymerase and ribonucleotide reductase enzymes. When it comes to the DNA polymerase, they are enzymes that create DNA molecules by assembling nucleotides, the building blocks of DNA, and are essential to DNA replication and usually work in birds to create two identical DNA strands from one original DNA molecule. And the ribonucleotide reductase, or RNR, is the enzyme provides the precursors needed for both synthesis and repair of the DNA. For the mechanism of action of the gemcitabine, it inhibits the DNA synthesis by inhibition of DNA polymerase and ribonucleotide reductase. The phosphorylated active metabolites gemcitabine diphosphate and gemcitabine triphosphate. Gemcitabine diphosphate inhibits DNA synthesis by inhibition of ribonucleotide reductase, and gemcitabine triphosphate incorporates into DNA and inhibits DNA polymerase, and as a result of that inhibition of the DNA synthesis. Anti-metabolites S phase. Capecitabine, fluorouracil. Mechanism of action: pyrimidine analog, inhibits thymidylate synthase, which depletes thymidine needed for DNA and RNA synthesis. Capecitabine is an oral prodrug of 5-FU. Fluoxuridine, analog of 5-fluorouracil. Gemcitabine and cytarabine. Pyrimidine analog, which inhibits DNA polymerase and causes chain termination, causes DNA breakage. Fludarabine, adenosine analog, which inhibits DNA polymerase when incorporated into DNA, causes DNA breakage. Methotrexate, folate analog, and inhibits dihydrofolate reductase, depletes purine and thymidine nucleotides necessary for DNA synthesis. Leucovorin folinic acid, used for reversal of methotrexate toxicity and as a part of chemotherapy regimens. Hydroxyurea inhibits ribonucleotide reductase necessary for DNA synthesis. Cladribine, adenosine analog, causes DNA breakage. Azathioprine, 6-mercaptopurine, 6-thioguanine, inhibits purine nucleotide synthesis.